Hey everybody, this is Dr. Kachikian from the Eye Institute. We have a case today. This is a patient who had cataract surgery followed by retina surgery, and you can see his capsule is all phimotic. And I'm not really certain of the reason, other than I think there was some retained cortex, as we will see, and I think the retina procedure probably destabilized the capsular bag with the vitrectomy and the loss of the vitreous and the loss of support of that hyaloid face. So when I saw him, I thought maybe we could yag the bag to relieve some of the stress, but I decided that wasn't going to be possible. So we decided to go in, try and free up the lens, maybe replace it with a three-piece lens. Let's just see kind of what's going on in here, see what we can clean up. So we make a few side port incisions. We inject some viscoelastic, and fortunately, the viscoelastic goes right in to the capsular bag. I think the way the phimosis and contraction had developed, I think that um, there was actually an opening under the anterior capsular leaflet, and so we got some viscoelastic right back in there, and we're able to expand the bag into the fornix, really 360 degrees. You can see here how the lens is becoming mobile, and you're seeing some of that retained cortical material that never came out during the original cataract surgery. I do think that's probably one of the main underlying reasons this happened, is retained cortex that maybe was not visible at the time of the procedure. I don't know. I didn't do the original cataract surgery. But we've opened up the lens capsule with viscoelastic. Now we're going to go in with IA, and we're going to get rid of that cortex. Why? Because I can't really see what else is going on. I really want to be able to identify um, where is the capsular bag phimotic? Where is there just retained cortex? Is the capsular bag open to the capsular fornix? Like, what's going on here? Where is this lens being held up in specific areas so that I can just address those areas? And so you'll see that we do this a few times where we fill up with viscoelastic or some sort of um, viscoelastic material, viscode or provisc, and then go back in with IA and just try and get a better view of what's going on. So you can see now we've removed all that cortex that was in the capsular fornix, and you can see that the capsule is actually clear. There's a rim of phimosis centrally and some capsular contraction inferiorly in the view there. And the more of this scar tissue you can remove, the more relaxed that capsular bag will become, and the less likely this will be to reoccur. You can see one of the haptics is just kind of stuck in that phimosis. Maybe we can free that up. And this is where we'll go back in with some viscoelastic and try again. Where focally is the problem area, and let's try and free it up. And you really have to, go back and forth a couple times, especially when there's all that retained cortex. So we'll use maybe a Sinskey hook and try and free up the haptic and get that lens to rotate. Ideally, you can see that the haptic superiorly in the view there is still kind of bent on itself, so that may or may not be totally open. Oh, there we got some opening going. There we go. That was it. That capsule had fused together, I think, in that spot. And a little more visco. We'll see if we can get this lens to hopefully be freely spinning in the bag is what I'd like to see. Get that inferior haptic freed up. Get it so the superior haptic can expand. There we go. That inferior haptic is now free. So that capsular opening is kind of small, but we may be able to address that later on. But now we've really gotten to a point where it looks like the capsular bag is free to the fornix in most areas, maybe not inferiorly there in the view just yet, but in most areas it's been freed up. And that's what we want. And spend a lot of time just trying to get out any residual cortical material that I can see. And now, I mean, how old is this case? How long ago did this cataract surgery get done? It's probably just over a year. And So you really want to get out of any remaining cortex and fibrotic material that's in there to allow that lens to move around freely. You can see it now, just trying to get it open up all the way by pushing the lens, opening up the capsule all the way to the fornix. And given that the case is a year old or more, you can see how the capsule is more robust. I mean, it's going to take a beating really as you move that lens around, and you want to be gentle, but it's not going to be like a fresh capsule that may be more fragile. There's going to be some fibrosis here. You want to obviously be careful of the zonules to not dehiss any zonules in any areas. So now I think we've got this freed up all the way to the capsular fornix. And the next step I think is going to be that we should really try and put in, either leave the lens in or remove it and try and put in a capsular tension ring, because we want to keep this capsule open. You can see there on the right that haptic is really pretty far expanded, maybe not 100% into the fornix, but pretty far, and that's true in both nasally and temporally there, or left and right in the view. So here we go with our capsular tension ring. For some reason, at the moment, we can't get these preloaded ones. We have to get the unloaded, and a lot of times I will put these in manually. You can just kind of spin around the capsular bag from the main incision in routine cataract surgery, but that only really works well if you only need one hand. You really have to have two hands to do that, and both of them have to be pushing the capsular tension ring in, okay, which is fine when the capsular bag is open 360 degrees and is not going to get hung up in any areas. In this particular case, I'm very concerned that the leading edge of that capsular tension ring is going to get caught. And so as I do with the preloaded capsular tension ring, I use a Sinskey to hold the leading edge of the capsular tension ring. And that allows the remaining part of the ring to expand without a focal point that can get hung up. And there you go. It just kind of pivots around the Sinskey, goes right in, and then expands. In a routine cataract surgery where you don't have an injector, you can really just inject the capsular tension ring manually, hand over hand, or place the capsular tension ring manually, hand over hand. Now you can see, so this capsular tension ring went in, but it did because the lens is already in the bag, which is usually not how we would place these. The capsular tension ring and the haptic are a little bit tied up in the periphery there, so we've got to address that because we don't want them to be totally separate, and we don't want the capsular tension ring kind of intertwined with the haptic. So we'll work, it looks like an Alcon lens, we'll work on just getting that haptic out of the way of the capsular tension ring. You can see there that it's not, it's over. So we will kind of manipulate it to try and just get it on the opposite side of that capsular tension ring so it's not overlapped. And that will allow that, there we go, that capsular tension ring to expand. Be careful of those zonules, you're pulling on them. That will allow that capsular tension ring to expand and keep the phimosis from occurring. And we'll rotate and we'll get this haptic kind of where it needs to be. Probably a little more torque on those zonules than I wanted to see in reviewing this case. You can also question whether there's more cortex out there. It looks like the cortical cleanup was really not good at the beginning of during the original cataract surgery. All right, so now both haptics are free and not intertwined with the capsular tension ring, and the capsular tension ring appears to be in the fornix of the capsular bag, which is awesome. That's exactly what we want. And there's part of me that was just ready to be done with this case after cleaning up all that viscoelastic, because the lens is now centered. We've removed the cortex that shouldn't be in there. There is some capsular phimosis, but it looks like at least the posterior aspect of the capsular bag has really been opened and the lens is centered and it's not bent or causing, there's no bending of the lens that's causing any undue refractive error. But then in looking at this, I really got to wondering if we could recreate that capsular rhexis. At the beginning of the case, I wasn't even sure I'd be able to free up the lens adequately. Now I'm just going to kind of remake that capsular rhexis. So what we'll do is kind of get to the point where we can reinflate with some viscoelastic. Here I am trying to just get rid of some of that fibrosis with the IA tip, and it's just too stuck on there. It really is. But again, the more fibrosis you can remove, and you'll be surprised how much fibrosis you can remove just by peeling it. The more fibrosis you can remove, the less likely this is to reoccur in the future. So we'll grab our MST kind of micro graspers or micro capsular rhexis forceps and pull. You do have to pull kind of aggressively. Sometimes it's a little bit uncomfortable, but you'd be surprised at how much stuff comes off of there. And try and try. Clearly that's pulling a little too much for my comfort at this point. So we'll try and cut that little trailing edge there, and then what we'll try and do is also cut the remaining area of the capsule, because you can see that just past that area of fibrosis, there's actually some clear capsule there, and that can still be torn. That is not scarred, and it can still be torn if you can cut through it adequately to get to a point where you can tear. So let's see what we can do here. We'll cut that with our MST graspers. And let's see how much we can tear here. It'd be nice if I reinflate it with a little more viscoelastic. It looks like that eye is a little bit soft. Let's see what we do. Nope, no such luck. There we go. So we will recreate this capsular rhexis, do that kind of little maneuver where you pull centrally. Again, it would have been nice if I had reinflated viscoelastic. It probably would have had a more round capsular tear here. Let's just see what we can get. We can get it to the point where we had made that original tear. No. Go back the other direction, or just cut it off. Either way, you removed a large area of fibrosis that might have continued to become phimotic. Let's see what we got here. Let's see if we can cut this. I don't know. There's been a lot of traction on that area already. Just cut that off there. There we go. Normal capsular rhexis forceps. See what we can do here. Perfect. Get that little remaining bit maybe. But now obviously the anterior capsular opening is much more round. We've removed some of that scar tissue there. And I think this will give this patient a better kind of view, less distortion. Remember, he's already had retinal surgery, so I don't know his vision. It's going to be optimal to begin with. I don't think it's going to be down to 20/20. Because I think it was a pretty big retinal detachment. But it'll give a better view. There'll be less scarring. He can have a YAG in the future, because I think he'll need that posterior YAG. And I don't think the anterior capsule is going to come down any further. So that's much more round. So what we'll do is get back, finish up our IA, see what else we can get out of there, and seal up our incisions. I'm kind of be happy that we did not have to do an ILL exchange on this patient, because he's got additional capsular support already. We put a capsular tension ring in. I like to keep the lens in the bag if we can, rather than put one in the sulcus. I think intracapsular fixation is the best. If the lens does dislocate, we can always fixate using that capsular tension ring. So I think that is very good. And we will seal up our incisions. Work on calling it a day. Looking to see, using BSS to push back the iris to see what might be in avoidance there. You'll notice you can't really see the capsular tension ring in the periphery, which means it's pretty far out in the periphery. And that was viscoed on there. There we go. Clean that up. I always put viscoat on the cornea to prevent the cornea from drying out during the case. I think it makes a huge difference. And that's our case. So I hope you folks enjoyed this one. I thought it was interesting given the severity of the scarring. But this patient really did great, was very happy afterwards. Still, I think, needs to have a YAG, which we'll do in a few months once things have settled down. But it really came out well. Hope you folks have a great day.